Hello, this is Lee Learman from the Florida Atlantic University with our second short didactic presentation in preparation for the flipped classroom on perinatal depression. This one will focus on treatment. We will describe a step-by-step management plan for uncomplicated perinatal depression, recommend a limited formulary featuring medications with multiple uses in women's health, and go over the benefits and harms of depression medications during pregnancy and lactation. Before we get to psychotherapy and medications, I'd like to spend a moment talking about other psychosocial interventions that can provide important support for patients newly diagnosed with perinatal depression. Patients should be assessed for adverse personal relationships, which may fuel the fire of mood disorders. They should be assessed for family and community support. They should consider self-help groups to provide additional support. And if they would like to pursue watchful waiting with periodic follow-up, this very disempowering disease of depression can be very challenging, and if the patient wants to step up and pursue watchful waiting, I think that's very appropriate unless they have very severe symptoms. I'd like to recommend the SPEAK interventions to help patients through the initial period before their psychotherapy or medications have had a chance to succeed. S stands for scheduling regular activities, keeping a calendar and a schedule, including P, pleasant activities, the things the patient knows she likes to do. Schedule those into the week. Exercise is important. Even just regular walking can be helpful. A, assertive communication and behavior. And K, thinking kind thoughts about yourself. Exercise has been shown to be an effective treatment for depression in its own right. 39 randomized trials with over 2,000 patients show that exercise is more effective than no therapy and is approximately as effective as medications and psychotherapy. Therefore, if a patient wishes to use exercise instead of the other treatments with close follow-up, that is not only very appropriate, it will also bring additional benefits to her health. So this is a very reasonable choice for patients to make. The MacArthur Initiative's Stage 4 in its systematic approach to depression care is monitoring. Once the patient has been started on a regimen, it is important to monitor symptoms, function, and compliance. We should be scheduling 3 follow-up contacts in the first 12 weeks, at least one with those of us who prescribe the medication, and the 2 other contacts could be with someone in our office or a pharmacist. The patient should remain on medications for 12 weeks to maximize the effectiveness, although they should start to get pretty close. At 6 weeks, there's additional benefit through 12 for the SSRIs. They should remain on medications for a total of 6 to 12 months, or they should be on chronic medication if this is a recurrent episode of depression. The monitoring is continued through the point of remission. This means return to normal functioning. It means the PHQ-9 score. If we use that to screen for depression, it provides us also a symptom score. We should be following that to assess improvement, and that should have normalized in order to call this a remission. If there's a partial or no response, we should assess adherence, reevaluate for other conditions, adjust the dose, change the meds, or refer to a psychiatrist. Before we get into specific side effects, there are some general principles for managing side effects. This includes allowing the patient to verbalize her complaints, listening carefully, providing support. If the symptoms are very bothersome, to recommend lowering the dose temporarily to see if we can get to a sweet spot with benefits and harms. We can treat the side effects if the patient is very happy with the effectiveness of the medication. We can treat the side effects with a second medication, change meds, stop meds, or start counseling. This and the next table summarize the common side effects. These are adapted from the MacArthur Initiative's publication, which I shared in our last didactic presentation. These are from the appendices, and they go over the various side effects, the various classes of medications, and a management scheme to consider for each of the side effects. Rather than taking the patient through each of these possibilities, I discuss generally the most common side effects, and that the patient should let us know if they have any bothersome sedation, dryness, etc. I do not go over these in detail because I am concerned about inducing what's been called a nocebo effect, in which by mentioning things to patients in too much detail, we can actually make them more common. In the way that a placebo effect provides benefit, the nocebo effect can create harms if we go too far here. Nevertheless, as a resource for clinicians, this is an extremely useful table that we should keep in our pockets. It includes a wonderful listing of all of these side effects and management strategies, ranging from sedation, dryness, GI distress, nausea, restlessness, jitters, tremors, and headache, to the side effects of insomnia, sexual dysfunction, seizures, weight gain, and rarely a granulocytosis. A very helpful table. We need to pay attention to SSRI discontinuation syndromes. These can be avoided by tapering drug in weekly increments. Otherwise, the patient will experience an uncomfortable array of somatic and psychological symptoms. This starts within 1 to 3 days after stopping. It can last up to 10 days. Most of the time, it's mild and transient. There are case reports of severe syndromes. The drugs with the longer half-lives and the shorter half-lives have a bit of a difference in how commonly this would occur. We should reassure the patient that non-compliance is the reason for discontinuation symptoms. It won't just happen. If she takes her medications as prescribed, she should not experience this. So please take it at the same time each and every day. Psychiatry referral has been discussed previously during the screening and diagnosis phases. It is also appropriate to consider here during treatment phase if the patient requests it, if we identify substance abuse, if we are confused as to the diagnosis, if we're concerned about safety, if the patient discloses other psychiatric medications, or if we're struggling with medications to get the patient the kind of full response that she deserves. We should explain the reasons for referral, remain involved, make it clear that we will continue to manage the patient together, and that we care about her and want to make sure that she understands this is an illness, it has a treatment, and we just aren't fully equipped to be able to help her through the more complex aspects of this treatment. Let's turn to SSRI safety in pregnancy. This was the subject of a systematic review in obstetrics and gynecology in 2014 with 6 randomized trials and 15 observational studies. There was low-strength evidence from 5 observational studies which looked specifically at SSRI safety in pregnancy. It found a small difference in neonatal respiratory distress syndrome with a number needed to treat of 16. It found a small difference in preterm birth, which was not significant, same with neonatal convulsions. It found malformations were looked at in 2 small studies. One showed no malformations and one showed a non-significant difference favoring safety of SSRIs. So all told, we have a very small difference in neonatal respiratory distress, which is difficult to replicate, as well as no demonstrated increase in malformations. So this was the state of the evidence back in 2014. A little bit later, we'll talk about some recent studies. SSRIs for postpartum depression have been studied also in a systematic review. Unfortunately, low-strength evidence from 6 randomized trials and 1 observational study, most with high risks of bias. Only 2 trials shed light on this, showing that psychotherapy or paroxetine, they work better by themselves than when combined together, so that we should probably just choose one modality and not both for postpartum depression. There doesn't appear to be a benefit of adding a second modality. I'd like to talk about how we develop a formulary for our women's health practice so that we don't get scared to provide depression medication when we need it. There are several different drug classes that are useful to us to prescribe across a wide range of clinical entities that we see in women's health. Using some basic principles on this slide, we can come up with a short formulary of drugs that can be very useful to us across a whole variety of conditions. Bupropion or Wellbutrin or Zyban is useful not only in depression but in smoking cessation. It lacks some of the bothersome side effects of the other drug classes. Duloxetine or Cymbalta is an SNRI, which is a good treatment not only for major depression but also for generalized anxiety disorder and neuropathic pain. It's an activating drug and we have to taper it to avoid discontinuation. Paroxetine or Paxil or Brisdel is an SSRI. It is the only SSRI that has a particular implication for cardiac malformations, which has not been proven but is a concern to many. And so we still recommend that other drugs or psychotherapy be used in pregnancy and not paroxetine. However, for non-pregnant major depression, anxiety, panic disorder, social anxiety, hot flashes, a very effective medication, less activating, mildly sedating, and less taper. Amitriptyline or Elavil is a great tricyclic. We use it for depression as well as anxiety and neuropathic pain. As you can see, bupropion is pregnancy category B, duloxetine C, paroxetine D, and amitriptyline C. We should use these medications when benefits outweigh potential harms. In patients that have been very happy with the control of their depression symptoms, it is quite appropriate for them to continue using these medications through pregnancy. However, if patients are concerned about the potential impact on their pregnancy, psychotherapy can also be very effective for patients if it is accessible to them. I wanted to take a moment to talk about collaborative care models because this is really what the Preventive Service Task Force was talking about in terms of adequate resources to provide effective depression care. It is not enough to simply know how to refer a patient for psychotherapy or know how to treat them with medications. Optimizing the outcome for depression care involves a team that includes a medical doctor, a mental health specialist, and a case manager. You can see all of the very important duties of the case manager. This can be a nurse, nurse practitioner, social worker, or pharmacist. The settings in which these collaborative care models have been used the most are those that are more value-based. They're willing to spend the money on this model of care because that same health system accrues benefits later on with saved expenses for patients that would have been inappropriately treated or incompletely treated. So, for example, Kaiser of Northern California would have an incentive to provide this level of collaborative care because if it does not implement this, it would have to bear the downstream costs and morbidities to patients of not establishing the best possible care practice. In fee-for-service models, this is much harder to create. A systematic review in 2012, including over 24,000 patients worldwide from randomized studies, showed conclusively that collaborative care was better than routine care for depression, better for anxiety, resulted in more guideline-consistent use of medications, resulted in improved quality of life and patient satisfaction. No question that it is a superior model. This concludes the second overview of treatment for our flipped classroom, the first being on screening and diagnosis. I'd like to take a moment to talk about some additional tips and resources for our classroom. First, I just want to go over our discussion points, which are listed on this slide. Many of these are topics that we've covered in our didactic presentations. However, by using case vignettes to discuss these, we will come to understand how to implement them in our practice in a much more concrete, tangible, and useful way than what was presented to you in these short presentations. There are pre-readings I'd like you to be aware of. Two of these are from ACOG, and they provide an efficient overview of screening tools and drug safety from a committee opinion and a practice bulletin. Both are excellent and efficient ways to gain the information needed for the flipped classroom. I also wanted to give you the U.S. Preventive Service Task Force summary publication in JAMA, which goes over the basis for how it established its recommendations. There's some great information there on screening tools and the benefits and harms of psychotherapy and pharmacotherapy. Please review all of these in advance of the flipped classroom. There are some optional readings here that are noteworthy because they were published after the systematic review and Preventive Service Task Force had a chance to look over the data on the potential harms of SSRIs in pregnancy. The first study was one of these fantastic Scandinavian studies that takes advantage of its wonderful database from 5 Nordic countries looking at the birth defects in 36,772 babies exposed to antidepressants with the rate in over 2 million unexposed infants, found that the rates of birth defects were quite similar between the two groups, 3.7 versus 3.1%, and that small difference disappeared after statistical controls for baseline differences. So in this gigantic study using outstanding high-quality data from 5 Nordic countries, there were no increases in birth defects in statistical analyses based upon this cohort. So this is very reassuring. They even used siblings to control for potential biases, and once they did that, all the differences went away. In the second study published in JAMA, this is a study that raised a lot of concerns because it showed that risk of antidepressant use late in pregnancy might cause persistent pulmonary hypertension. However, these were very rare events, and these also went away after adjustment for multiple confounding variables. The authors concluded that there may indeed be an increased risk, but their own analysis indicated there was no such risk after adjustment. So in these two large cohort studies published since the latest systematic review, we find no evidence that use of antidepressants early in pregnancy or later pregnancy confer any particular risks to the newborn that we've been able to identify, at least at this time. So with that, I wish you well, and I look forward to seeing you for our flipped classroom. Thank you very much.